Are you able to see my screen, right? Hello?
Hello. Yes,
Yeah.
you. We
Yeah.
can.
Thank you,
We can
guys.
have.
Yeah. So today onwards, we can discuss the ICD 10 cm course related concepts. Okay, guys. We can discuss just 3 days of ICD 10 cm or 2 days maximum. Today and tomorrow, ICD will be complete. Clear because all are working in the ICD 10 cm, right? Everybody aware of ICD 10 cm code leading, correct? Simple. Everything should be multiple choice questions. Just we need to identify the code in tabular list. No need to lead in index and all. Just you can identify the code in tabular list and eliminate the options. First thing, while we are coding the ICD 10 cm course, we need to follow the sequence rule. Okay? Sequence rule should be most important for the ICD 10 cm coding. Okay? So, lot of the questions you will get same course in the two options. సేమ్ కోర్సు మీకు రెండు ఆప్షన్స్ లో వస్తాయి జస్ట్ వీ నీడ్ టు ఎలిమినేట్ ద ఆప్షన్స్ ఓకేవా జస్ట్ వీ నీడ్ టు eliminate the options. For example, see this question. If you observe option A and option B same codes, right? And option D, option C same codes, correct? They just change the sequences, correct? Here, if you observe, they given A, B, B20 point, comma, B59, B59, comma, B20, Z21, comma, B59, B59, comma, Z21. All the four options, we have two sets of codes, correct? Just we need to identify what is the exact code sequence and what is the code. So identify the code based on your knowledge.
Option A.
Option
A.
A, correct. So here you need to apply the HIV related illness guideline. The patient have HIV related pneumocystitis pneumonia, pneumonia due to AIDS. So when the patient have AIDS related illness, always should be what is the sequence? AIDS first of all. What we need to give the sequence first? AIDS B20. Okay. When the patient have AIDS related illness or AIDS B20 or Z21, what you will code? If the documented HIV related illness, it should be B20 or Z21.
B20.
P20. When we need to code Z21? Asymptomatic HIV. When there is no symptoms of HIV or HIV, known HIV, if they documented Z21. Suppose if they documented AIDS related illness or AIDS, HIV disease, HIV related illness, symptomatic HIV, in the past patient have symptoms, we need to consider as P. When the patient coming with the related illness, whether in the current visit or previous visit, the patient have AIDS, irrespective of treatment, always AIDS should be sequenced first. If the patient coming with unrelated illness and the patient have AIDS, then suppose patient have HIV related pneumonia, you coded AIDS first. Suppose patient have HIV and fracture, what you will code first?
Fracture.
Patient have
Unrelated
HIV and
illness.
fracture, then
Fracture code first.
fracture we need to code first. Okay. Unrelated illness, when the patient have unrelated HIV related AIDS, unrelated diagnosis should be sequence first. Okay, no? Related unte HIV code చేసుకోండి P20, unrelated unte unrelated diagnosis ఏది ఉంటుందో అది కోడ్ చేసుకోండి. Okay, P20 at the time of unrelated diagnosis should be sequence first. So all the ICD guidelines based on the sequencing only. Okay, if you are aware of the sequence, you will get easy. If you are not aware of the ICD sequence, it should be very difficult to clear the exam. Clear? So most of the questions you will get sequencing based only. Everybody have idea about chapter specific guidelines? ICD chapter specific guidelines? So how many chapters we have in ICD? How many chapters we have in ICD? How many chapters only?
I think 22.
22 chapters we have for the ICD. Okay. So everybody have idea about conventions. Exclude one, exclude two, code first, code also, underlying disease, cause and effective relation, etiology, manifestation, colon, semicolon, bracket, parenthesis. This everybody have idea, right? Thank you. What is the meaning of code first? కోడ్ ఫస్ట్ కాన్సెప్ట్ టెల్ మీ అందరు తలాడించారు కదా తెలుసు చెప్పండి. సో వాట్ ఈస్ ద మీనింగ్ ఆఫ్ కోడ్ ఫస్ట్ కాన్సెప్ట్? ఆన్సర్ చేయకుండా సైలెంట్ మాత్రం ఉండకండి. What is the meaning of code first? When you see the code first means that diagnosis we need to give in the sequence first. For example, anemia due to neoplasm. If you go for the anemia diagnosis code, what is the code? D630. Okay. If you go to this code in the tabular list, you will get code first concept. See here, they documented clearly anemia in neoplastic disease, code first neoplasm, which means while we are coding D630, first we need to code the neoplasm code in the sequence. If you added the D630 and if you coded neoplasm, it should be wrong. First we need to code neoplasm, then D63 code. Okay, well, this is the sequence first, code first. So whatever the documented code first means that diagnosis we need to code first. Clear? Then use additional code means tell me. Use additional code means. We need to use additionally that code. Okay. Secondary
Additional
only we need to code
two
that
code
additional.
may be required to fully capture the condition.
Two codes required. That code should be additionally. Suppose patient have DM with CKD. How we need to code? 1122, then additional code. If you go to the 1122, they documented clearly use additional code of the CKD. Use additional code to identify the CKD stages. Additional code means that code should be additionally we need to give. Suppose one question you will get, patient coming with ESRD, patient is on hemodialysis, past medical history have diabetes. So patient treated in the current visit, ESRD. What is the sequence first? Age first इवाले 1122 only we need to give the
1122
sequence
only
first.
first.
You do not check ESRD they are treating, why we need to give the past history diabetes. We have the combination code here. While we are coding diabetes and ESRD, we need to look always sequence E series code, diabetic complication code only sequence first. The CKD codes we need to use as additionally. That means additional second code only we need to give. Clear? So use additional code means that code we need to give second. Sometimes code also means if required, that code also you need to add. Add code also diagnosis. Okay. If required, add the code also diagnosis. Okay. Code also diagnosis. Suppose you are finding the viral vaginitis or bacterial vaginitis. You will code the diagnosis and code also the type of infection. B series code also we need to use. Okay, these things you can remember. Then exclude one and exclude two, everybody know, right? Exclude one means what is the meaning of exclude one? Not coded here. We should not
Okay.
code the two diagnoses together. One question you will get from this concept, guys. Note down. Patient coming with emphysema and COPD, how we will code? One multiple choice question you will get from this concept.
Emphysema.
Yes, correct. So, options you will get code COPD, code emphysema, code COPD and emphysema, and 10 for the clarification. Okay. What we need to code? Code only emphysema. Answer. Next, acute and chronic conditions. In this concept also you will get one multiple choice question. Suppose they documented the diagnosis acute and chronic. How you will code? We need to look for the combination code. For the diagnosis have acute and chronic combination. For example, acute and chronic respiratory failure. You will go with combination code. There is no combination code. There is no combination code. Both they documented separate sub-entries. At that time, how we will code? Suppose they given acute and chronic renal failure. We have combination code. We have combination code for acute and chronic renal failure or not?
No, sir, we don't have.
No, we don't have a combination code. Then how we need to code?
Always code acute phase of a condition
We
first.
need to code separately. Very good, bro. Acute should be sequence first, then chronic. Okay, you will get one question, same question you will get a patient coming with acute and chronic renal failure. How you will code the scenario? Okay, code both. What should be sequence first? Acute should be first. Clear? Huh? Two questions you will get from this parenthesis. Exclude one note, COPD and emphysema, and acute and chronic conditions, how you will go. Any doubt in these two concepts? Clear, right? These two questions. Then you know, right? Parenthesis, bracket, okay, and with etiology manifestation. Etiology manifestation means tell me etiology manifestation. What is the meaning of etiology and manifestation? Whatever you know, you can tell me. No problem. Primary condition responding to the
Etiology cause a main disease
cause of etiology. Suppose, give me some examples.
like diabetes is a etiology and the sub manifestation are like neuropathy, nephropathy, retinopathy are the
Suppose if the
manifestation.
patient have diabetes, we have lot of complication manifestations. It was very easy example for all the diabetic complication: kidney, neuropathy, nephropathy, foot ulcers, retinopathy, ketoacidosis. Okay, we have lot of manifestations due to the underlying disease. Any complication that developed, it should be the manifestation of the disease. Here, first thing remember while we are coding the etiology manifestation, some combinations we can assume the relationship directly. Okay, for some combinations they need to must document the link. Kada? For some diagnosis complication, they we can assume, suppose they given hypertension and CHF. No need to check the linking, correct? We can assume the linking anywhere: CHF, CKD, hypertension. This combination we can take from anywhere. Suppose diabetes, they documented in past medical history. Foot ulcer, they documented in assessment. How you will go? Combination, we can assume the combination. Suppose patient have past medical history diabetes, assessment cellulitis. Then how we will code?
Then we need a linkage of diabetes or
We need
cellulitis.
linking compulsory. Okay, if they documented linking, we can assume. Otherwise, we should not able to take as complication. Suppose they documented cellulitis due to diabetes, we need to go with complication. Otherwise, we need to code separately. Okay, this you can remember. For some diagnosis, we can assume default linking. For some diagnosis, linking must be documented relationship. If they not documented relationship, then we should not take the complication code like combination code. For some diagnosis, automatically we need to assume the combination code. Okay, this you can remember. Okay. That's it, guys. For conventions, you will get the question from acute and chronic and exclude one COPD and emphysema in these concepts. Next, come to the chapter 1. What is the chapter 1? Infectious and certain parasitic diseases. Okay, infections and certain parasitic diseases. First concept in this chapter: HIV, AIDS. Okay, how you will code the HIV?
I have a doubt. I have a doubt.
Yeah, bro.
If we have CKD, hypertension, and heart failure, then what is the sequencing? Like we have to
First,
put
we need to
disease
go with
first or
hypertension combination, then heart failure, then
yeah?
CKD. CKD third. Okay.
Then last T series.
Yes, yes. Hypertension, heart failure, then kidney failure.
And what about diabetes?
They given the diabetes also, then see hypertension, heart failure,
Okay.
diabetic complication, then CKD.
Oh.
So first concept, HIV/AIDS. So code only confirmed cases. Which means we should not take the unconfirmed diagnosis like possible, probable, suspected. We should not code. Okay. If they confirm the diagnosis, we can take the HIV or AIDS. Do not consider probable, possible, or suspected diagnosis. Then, when we need to code Z21, when we need to code B20. Asymptomatic HIV. Asymptomatic HIV. HIV positive. Known HIV. We need to go with Z21. Yeah. When we need to code the B20. HIV related illness. AIDS. HIV disease. Symptomatic HIV. HIV. Symptomatic HIV. We need to go with B20. My question, I will ask one question. I don't know. In the current visit, patient coming with the HIV. There is no symptoms in the current visit. In the past, patient have HIV symptoms. Like 1 year back, developed symptoms. As of now, there is no HIV related symptoms. Ongoing the treatment only for the HIV. B20 or Z21. In this current visit,
B20.
no symptoms. Previously, 1 year back, have HIV symptoms. So it should be B20 or
B20.
Z20.
Should be
B20.
What you will code? B20 or Z21?
B20.
B20. Once symptoms develop, from that visit, all the subsequent encounter, we need to add B20. Okay. AIDS should not convert to HIV. Okay. Once you added the B20, from that visit onwards, all the subsequent encounters, we need to add only B20. Okay. Once added the B20, that's it, guys. Do not add Z21 or R75. Inconclusive HIV or asymptomatic HIV, we should not add once you added the B20. Clear? If you know patient have symptomatic HIV, then from that visit, all the subsequent encounters B20. Clear? If you added the B20 for the patient, do not add a Z21 again. From that visit, all the subsequent encounters only. What you need to use? B20. Clear? Come to the sequencing guidelines for HIV and AIDS related. Patient coming with HIV disease with counseling. Patient have HIV disease and they have done counseling. You need to give HIV disease B20, then counseling code. Then patient have HIV with counseling, not HIV disease. Just they documented HIV infection Z21, then counseling code. Suppose patient admitted for unrelated condition like traumatic fracture of left femur. Patient have HIV and admitted for unrelated condition. What is the sequence first? Unrelated condition like fracture, then HIV disease, B20. Patient admitted for HIV related condition like Kaposi sarcoma. What you will give first? B20 always, we discussed, right? HIV related means clear. B20 should be sequence first, then HIV related illness. I will give one question, try to answer it. Try to answer the third question. Third question you can try this.
R75.
Third one.
Second one. B. B option.
Option D.
Yes,
Option
option
B.
B.
Option
B.
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 Correct. B20, then
Second.
suppose is sarcoma. Okay, HIV related illness. Correct. So whether it was newly diagnosed or previously have, once related illness, always B20 should be sequenced first. Okay. When it was developed, no need to check. It was related, B20. Next, pregnancy complication. When the patient was pregnant and patient have HIV or AIDS, always what series code we need to give the first when the patient was pregnant? O series. Okay, for HIV or AIDS, we have only one series code O20 O98.7. Okay, then last character look for the trimester. First trimester or second trimester or third trimester or unspecified trimester. After that, you need to use additionally HIV or AIDS code. After O series, you need to give the additional code HIV or AIDS, Z21 or B20. Then weeks of gestation. Okay, weeks of gestation also we need to add additionally. Whatever the weeks, 20 weeks, so Z3A 20. Everybody know pregnancy guidelines here? Everybody code? No. Remaining everybody code. So you have idea at least O series we need to code the pregnancy, right? Yeah. So pregnancy we need to code O series. Then based on the weeks you need to add the weeks of gestation. Okay. For some diagnosis directly O series enough. For some diagnosis you need to add the other chapter specific code also. Normal ICD code also you need to add along with O series. Clear? Next, sepsis. HIV AIDS clear right now. Sepsis. So how we need to code the sepsis guidelines we can discuss. So when they documented sepsis, what we need to look first? Identify the organism. Identify the organism. Like we have the types of sepsis like streptococcus sepsis, staphylococcus sepsis, pneumococcal sepsis. Okay, what are the organism? What is the causative organism for sepsis? Okay, what is the meaning of sepsis? Tell me. Blood infection. How it should be developed? Blood infection. Not exactly. Not correct answer for the sepsis blood infection. Elaborate more. So, first tell me at least what is the local infection and systemic infection. Difference tell me. What is the difference between local infection and systemic infection? Local means particular system. Okay. If any infection affected to the particular system, it should be considered as local infection, urinary tract infection. Okay, upper respiratory tract infection, cellulitis, okay, COVID. If infection affected to the particular system or particular site or particular location, it should be considered as local infection. That local infection virus enter to the bloodstream. Once the infection enter to the bloodstream, what will happen? The blood circulate throughout the body, right? So it will be converted as systemic infection. It will affect all over the body. Okay, so it should be sepsis. Sepsis should be systemic infection. Okay, so now after developing the sepsis, we need to check causative organism. Due to what organism, what is the virus, what is the causative organism for sepsis? We need to look first. If they identified type of organism, code, specific organism code. Okay. For example, Staphylococcus sepsis. If organism not documented for unspecified sepsis. Clear? We need to go with unspecified. If you find any specified code, you go with specification. If they're not documented any specificity, we need to go with unspecified sepsis. Okay. Next. What is the next steps after identify the sepsis? What are the things we need to look for the document? Patient have sepsis. Then what are the things we need to look?
Blood culture, urine culture.
Treatment, okay, blood culture, fever and all. So next step further, if the sepsis was severe means, what we need to consider as severe sepsis. Severe sepsis, how we need to code? Sepsis plus severe sepsis. Okay. Sepsis and severe sepsis. Because sepsis I typed based on the organism, you will get the specific code. But severe sepsis R6520. Severe sepsis without shock. Okay, suppose the documented septic shock. How we need to code? Sepsis plus severe sepsis with shock. R6521. Sepsis with severe sepsis with shock. Next concept, acute organ failure. Same in the sepsis only. Acute organ failure. Patient have sepsis and they documented acute organ failure. Suppose sepsis have and acute renal failure. How we need to code?
We
Patient have
need
sepsis
provider
and acute
linkage.
organ failure. How we need to code?
Provider linkage.
Hmm.
For
Look
the
for the relationship.
yeah.
Do not consider default severe sepsis, guys. Okay, look for relation. If organ failure due to sepsis, sepsis, severe sepsis, organ failure. Organ failure unrelated to sepsis. Sepsis, organ failure. Relationship not documented. Patient have sepsis and acute organ failure. If they clearly documented related, you will go with sepsis, severe sepsis, organ failure. If they clearly documented unrelated, code sepsis and organ failure. But if they not documented whether related or unrelated, just they given the sepsis and organ failure. There is no relationship. Query for the relation. Query for relationship. Query means clarification. Okay. Query for the relationship. So in this concept, you will get one question. Okay. Patient coming with sepsis and acute renal failure, there is no relation between the diagnosis. How we will code the scenario? We need to write the query for clarification or relationship. We should not code sepsis and severe sepsis default if there is no relation or unrelated. Whenever they document an organ failure due to sepsis, then only go with sepsis, severe sepsis, and acute organ failure. Clear? Yeah. Come to the questions. Solve the 7 and 8. What is the answer for 7th question?
Option B.
Option
Can
B.
B.
Option B.
Sepsis, severe sepsis, pneumonia, COPD exacerbation, and hypoxia. Okay. Because they documented clearly severe sepsis with acute organ dysfunction. Then sepsis with septic shock. B. Sepsis and R65 to 1. Now only we discuss now. Sepsis with septic shock means RA41-9 and R65 to 1. Suppose they given only septic shock, then how we will go? They documented simply septic shock. How we will go? ఓన్లీ సెప్టిక్ షాక్ ఇచ్చారు, ఇప్పుడు ఎలా కోడ్ చేస్తారు చెప్పండి. They documented only septic shock. How you will code?
There is code first note under ICD-10-CM. Need to code
We need to
sepsis.
code sepsis, then septic shock. If they documented severe sepsis also, you need to code sepsis, then severe sepsis. Clear? Default, we need to code first sepsis. Whenever they documented severe sepsis or septic shock. So here, if they documented sepsis, we are going with unspecified sepsis. If they given sepsis due to E. coli, specific organism, you will go with specific organism code. If they documented severe sepsis, severe sepsis. Acute organ failure due to severe sepsis, severe sepsis, acute organ failure. Acute organ failure due to sepsis, same concept. Next, septic shock with acute respiratory failure, sepsis, septic shock, organ failure. Okay, same for newborn sepsis means P series code. Okay, what? Newborn means we have the P series code. For newborns P series, pregnancy O series. You have idea, right? Right. Severe sepsis due to Pseudomonas with septic shock. They given the specific sepsis organism. Then sepsis due to Pseudomonas, then septic shock. Now, note down the questions. What are the questions we'll get from the sepsis related in exam? First question you will get like, when the patient has sepsis and multiple local infections, what you will give the sequence first? Patient has sepsis, cellulitis, pneumonia, urinary tract infection. What is the sequence first? When the patient has sepsis and local infections, what we need to give the sequence first? When the patient has sepsis, always sepsis should be sequence first. Okay? When the patient has sepsis, always sepsis should be sequence first. Local infections second. Clear? So local infection should be second. Patient coming with sepsis and local infections like cellulitis, urinary tract infection, pneumonia. 6 code sepsis, then local infections, because sepsis should be the systemic infection.
If sepsis is developed during an inpatient stay,
Or sepsis developed after admission, then infection should be sequenced first.
so local infection should be sequenced first.
Correct. Because POAN conditions, we should not give the PDX, no.
Okay, so here like patient is
But
admitted with a
in
cellulitis.
one thing,
Mm,
suppose patient coming with local infection, maximum due to that local infection only sepsis developed, correct?
yes.
Then already patient have sepsis related illness, then sepsis should be sequenced first. If the patient coming with some procedure, they done the procedure, due to the procedure, post procedural sepsis developed, complication procedure, then complication should be sequenced second only. Okay, SDX only we need to give post procedural sepsis, but this sepsis you will go with PDX only, because it was developed due to local infection. Local infection was cause of the sepsis. Clinical indicator, right?
Yeah, so if local infection is there, if patient is admitted with a local infection and during his hospital stay, if he develop a sepsis, then we
Check
can code a
at the
sepsis
time of
first.
admission, is there any indicators or not? Like blood culture, this and all you can check. Okay, there is
Okay.
no indicators on. Okay, there is no indicators, no supporting at the time of admission. POA you are giving N for the sepsis, then SDX. Clear? Suppose if you go with POA Y, we need to give PDX. Look, when the
So
sepsis
if
develop, you are giving POA N or Y. Clear?
so first sequencing is based on the
When
what
the
the
diagnosis
patient is
what is the reason of admission?
reason for admission is main.
Correct.
So if scenarios come like which I asked to you, like if a question is like only 2 and
That
3
only I
line,
am
na?
saying. Suppose after the stay, Suppose patient coming with the cellulitis or urinary tract infection. They are treating the UTI. Okay. On third day or fourth day, they found sepsis. Correct?
Okay.
Third day or fourth day, they found the sepsis. First, look that sepsis due to local infection or not.
Okay.
If it was related, then sepsis only PDX.
Okay. If unrelated, then the
Local
local
infection.
infection first, and
That's
then sepsis. Oh,
correct.
the
But
sequencing will change.
but remember, sepsis default developed due to local infection only. We don't get unrelated maximum. Okay?
So
Sepsis
in
default due
exam,
to local infection only developed. Suppose one more concept. Patient admitted with cellulitis. Okay. And patient have post procedural infection. 1 week back they done the procedure like PICC line they placed. Clear? Huh? Now patient coming with cellulitis. 1 week back they placed PICC line. Procedure done. And patient have sepsis. They not documented how the sepsis developed. We have chances, right? Sepsis due to local infection, sepsis due to procedure. Procedural, post-procedural sepsis also we have, no? We don't have clarity how the sepsis was developed due to local infection or due to post-procedure. At that time, how we will consider? Patient have
need to
cellulitis
query.
and post-procedural sepsis. Sepsis, there is no clarity how it will be developed due to post-procedural or due to cellulitis. How we will code? We need to raise the query for clarification how the sepsis was developed. Then, if they develop due to post-procedural, then if they are admitted for the local infection should be sequence first, then post-procedural sepsis. Clear? Huh? Always look for the reason of admission. Patient have only local infection and sepsis, then default the cause of sepsis should be local infection only. Without local infection, it will not develop the sepsis. Okay? We don't get unrelated local infection due to sepsis. Default, local infection was one of the cause of sepsis. It also a clinical indicator of sepsis. Clear, bro?
Yes, sir.
Thank you. Next question. You will get one more question related to sepsis. What is the ICD-10 CM code for purpural sepsis due to MRSA? Purpural sepsis due to MRSA. Purpural sepsis, we have a separate code OA85. Okay. When they documented purpural sepsis, do not consider A41 series, A40 series codes. No need to code A40 and A41 series codes whenever you are using purpural sepsis. O85 we have code purpural sepsis, it will lead directly. Okay, no? Under sepsis purpural, if you check, you will get the code. Or based on the option, you can go with the code. You will get purpural sepsis. So while the documented purpural sepsis due to any infectious organism, we need to code additionally that specified organism. Okay, we need to code additionally specified organism. Here, purpural sepsis due to what is the causative organism?
MRSA.
MRSA, right? MRSA you need to code additionally. What is the code for MRSA? Check O85, they given all options same. Then B9620562, B956162. Just we need to go for that code in the tabular list and verify the description. What is the B9562? What is the B9561? B9620. Read the description and match which one is matching with the MRSA. That should be the answer. So go for the tabular list and identify the MRSA code. If you know already, no problem.
Yeah, for post-procedural sepsis, if you are reporting, we need to put underline sepsis code, like A series also.
Post procedural sepsis T series you will get, bro.
Uh, so A series, do we need to
Not
report A
required, no.
series also or
Only T series.
only T series?
Hmm.
Okay.
It should be ICD. What is the code for MRSA, guys? Everybody able to go for the code or not? Tell me at least. You are able to identify the code in the book, right? What is the code MRSA? P9562. Okay. We need to code sepsis, purpural sepsis and P9562. These two questions we will get from the sepsis concept. Then one question we will get from the query related, that patient have sepsis and organ failure, no relation, how we will go. Query for the clarification. Query for the clarification. Next, COVID. Next concept, COVID. Everybody have idea how to code the COVID? COVID also code only confirmed cases. Okay. If the COVID was confirmed, we need to code the COVID. Okay. Like lab test positive or COVID-19, if they documented, we need to code COVID. When the diagnosis confirmed, no need to code the related symptoms. Okay. Any diagnosis if confirmed, no need to code the related symptoms. Okay. Suspected COVID. Patient coming with the suspected COVID, negative. Result should be negative. Then look for the symptoms first. What are the symptoms if the patient have? That symptoms we need to code. Then suspected COVID diagnosis Z2822. Okay. You suppose patient coming with fever and cough, they suspected the COVID and they done the lab test. Lab test was negative. Code the fever and cough, then suspected for the COVID. Then there is no symptoms. Directly family members have COVID and they suspected for the patient also, and they done the lab test. COVID result negative. Then code only Z2822. Without symptoms, if they suspected, code Z2822 only. If the patient coming with symptoms and they suspected, code first symptoms and suspected COVID. If the COVID confirmed, no need to code the symptoms. Code directly COVID diagnosis U071. Then complications I have along with COVID, like pneumonia due to COVID, respiratory failure due to COVID. So always COVID should be first, then respiratory manifestations. Okay, first COVID, then respiratory manifestations we need to code. Remember, guys. Next concept, note down. Always give COVID sequence first. If confirmed, accept sepsis, pregnant, newborn, organ transplant complication. Okay, these are the exceptional cases. Remaining all the cases, if the COVID confirmed, COVID should be the sequence first. PDX. Okay. If the patient have sepsis and COVID, we need to go with sepsis. If the patient was pregnant, we need to go with O series code. Okay. Then newborn P series. Organ transplant complication other than kidney complication, organ transplant complication should be sequence first, even though if the patient have COVID. Remaining all the cases, COVID, if confirmed, COVID-19 should be the sequence first. Done? Clear, guys? That's it for chapter 2, chapter 1. Next, note down chapter 2, neoplasms. So, first, how we need to identify the neoplasm codes? Where you will find the neoplasm codes? We need to look for the neoplasm table, correct? After the disease index, you will get the neoplasm table. Open and identify the neoplasm table. You will get ICD 10 cm table of neoplasms, correct? First, what you find in the headings, check. Here you will get the neoplasm, then malignant primary, secondary, in situ, benign, uncertain behavior, unspecified behavior, type of neoplasm, and the locations you are getting, correct? So first thing, remember, while you are coding the neoplasm, if you find the code beside hyphen, have you observed? For some codes, you are getting hyphen beside the code. If you observe clearly, you get. See here, C49 1, they given the hyphen, right? C49 1. So if they given hyphen means it should be incomplete code. Okay. We need to look for the remaining characters in the tabular list. If they given like this, it should be a complete code. Directly we can take from the neoplasm table. If they given hyphen, it should be incomplete code. We need to look for the remaining characters in the tabular list. Next. First, while we are coding the neoplasms, we need to look type of neoplasm. Malignant, in situ, benign, uncertain behavior, unspecified behavior. What is the malignant neoplasm? Malignant means, what is the malignant neoplasm? Malignant means malignancy means, guys,
Cancerous. Cancerous tumor.
cancerous, spreading, correct?
Yes.
Spreading. Then benign means tumor, but it will not spread. Carcinoma in situ means hmm, cancerous cells, but it will not spread. Uncertain behavior, uncertain behavior. Uncertain behavior means unable to find whether it was benign or malignant. Okay, wa? Unable to find. That pathology was unable to find the tumorous cell was benign or malignant. So it should be uncertain behavior. Then unspecified, we are not able to find anything. It should be unspecified. So first thing, while we are coding the neoplasms, we need to follow the sequencing here also. Okay, we need to follow the sequencing. We have one table for the neoplasm in the book. If you go to the chapter specific guidelines in the starting, chapter specific guidelines you will get in the ICD book starting, right? Starting of the book, you will get chapter specific guidelines for each chapter. If you understand this table, you will get the neoplasm coding. Here they given reason for encounter and sequencing. Clear? So first to check treatment for primary malignancy. When the patient have multiple neoplasms, in the malignancy, primary means what is the difference between primary and secondary malignancy? Primary means origin of the neoplasm, where it will be started. Secondary means spread to the other location. For where it was spreading, it should be the secondary. Suppose patient have breast to lung cancer. What is the primary site? What is the metastasis? Breast is primary, secondary is lung. So breast from lung means breast from lung means lung is primary, breast is secondary. Look this one, to and from. Okay, to and from you need to aware. Clear? So when the patient have multiple neoplasms, they admitted for the treatment of primary site. Primary site should be sequence first. When they admitted for secondary site treatment, secondary site should be the sequence first. Reason of the treatment for which neoplasm they are treated in the current encounter, that neoplasm should be sequence first. Okay, irrespective of primary and metastasis, look for the treatment which is neoplasm they are treating, that should be the sequence first. Then when the patient was pregnant, Only one O series code we have for all the neoplasms, O9A.1. After that, you need to give the neoplasm code additionally. Then patient have neoplasm and neoplasm related complications. If they admitted for the treatment of complication, except anemia, remaining all cases, we need to code first complication. In anemia scenario, neoplasm first, then neoplastic anemia. Okay, now remaining all cases, complication if they treated in the current visit, complication should be sequence first. Suppose patient admitted for the neoplasm related pain in the current visit. They treated pain management. Also patient have bone neoplasm. What is the sequence first? Patient admitted for the neoplasm related pain. They done the pain management treatment and the patient also have bone neoplasm. What is the sequence first? What is the sequence first? Here, what is the reason they admitted? Neoplasm related pain, right? So when they admitted for the complication, complication should be sequence first. Okay, neoplasm related pain should be sequence first, then neoplasm code. Okay, if they admitted for patient have neoplasm dehydration first. Dehydration, okay, look for the treatment. If they treated complication, complication should be sequence first. If they treated neoplasm, neoplasm should be sequence first. When the patient have multiple neoplasm, which neoplasm site they are treating, that should be sequence first. Then, when the patient have pathological fracture due to neoplasm, what is the meaning of pathological fracture? Fracture due to underlying cause, underlying disease. When the patient have neoplasm related fracture, if they treated neoplasm in the current visit, neoplasm should be sequence first. If they treated fracture in the current visit, fracture should be sequence first. Then, when the patient coming with the complication from surgical procedure for treatment of neoplasm, if they're coming for the complication of surgical procedure, complication should be sequence first, then neoplasm. Just go through this table and ask me if you have any doubt. Any doubt in this table, guys? Clear on neoplasm related complications? Then, what is the treatment of neoplasm? Therapy, right? Chemo, radiation, or immunotherapy. So, patient have neoplasm. They are admitted for the therapy. What is the sequence first? Always therapy code should be sequence first. A patient have lung neoplasm. On the current visit, they are admitted for the radiation therapy. So, what is the sequence first? Radiation therapy. In this concept, we will get one question. Patient have neoplasm code and they admitted for the therapy. Always look for the therapy code should be sequence first. Encounter for radiation therapy or encounter for chemotherapy. Z51 series code you will get. If admitted for therapy Therapy code should be sequence first. Okay. Next, patient have anemia in neoplasm. What you will go to first? Neoplasm. When the patient have anemia due to chemotherapy. So patient have anemia due to chemotherapy and neoplasm. Okay. Current visit treated anemia. They transfused blood. What is the sequence first?
Anemia.
Anemia due to chemotherapy. We have the combination code. We need to go with the particular diagnosis. Okay. They treated the anemia means anemia due to chemotherapy D6481. Then neoplasm. Then adverse effect of the neoplasm. Adverse effect of chemo drug. Okay, no? Adverse effect of the chemo drug. T series code you will get. Clear? Huh? Next, chapter 3, we don't have any specific guidelines, guys. Chapter 3 was reserved for further expansion. Next, chapter 3 reserved for future guideline expansion. As of now, no guideline. Next, chapter 4 endocrine, nutritional, and metabolic diseases. Everybody have idea about diabetic complications? So if they not mention the type of diabetes, what we need to put default? Type 2. Okay, default type 2. While we are coding the diabetes, look for the complications. Some complications we can assume the default link. Some complications we need to check for the link. Sometimes the cause, complication code included in the diabetes. Sometimes we need to use the additional code. Okay. When we need to give additional code, what are the code ranges? We need to give the additional code of diabetes complication. Suppose the patient have diabetes and neuropathy. How many codes? How many codes you will code if the patient have diabetes and neuropathy?
One code.
One
1140.
code. Okay, 1140. So here we have the list. So type of diabetes and fourth character represent complication. 0 means hyperosmolarity. 1 ketoacidosis. 2 kidney complication. 3 ophthalmic. 4 neuro. 5 circulatory. 6 other skin related. Okay. So condition with assumed relationship. This diagnosis we can assume default. This condition link must be documented. This diagnosis, if the link we can take. Otherwise, we should not code the link. Sometimes we need to give the code also. Here we need to code this diagnosis additionally. CKD, diabetes CKD, glaucoma, and foot ulcer, osteomyelitis also we need to code. Okay, diabetic osteomyelitis. Additional code you need to use for the osteomyelitis. What is the treatment of diabetes? Hmm? Insulin or oral hypoglycemics, correct? Next, when the patient is ongoing long term use of medication, we need to code the long term use of medication also, right? For diabetes, suppose patient have diabetes, medication list documented insulin. How we will code? Diabetes we need to code on long term use of insulin. Suppose they given oral hypoglycemic and insulin both, then they given metformin, oral hypoglycemic and insulin. Both we need to code. Insulin we need to code and oral hypoglycemics we need to code. Okay, va? In the patient ongoing treatment with insulin and oral hypoglycemics, both we need to code. Insulin code Z794, oral hypoglycemic Z7984. Okay, va? We need to code both oral hypoglycemic and insulin if they documented. Oral hypoglycemic like metformin, glucagon. So where you will find the long term is of medication code in the book? How we need to find the long term is of drugs code? Okay, what? They will give the drug name. How we need to find that particular drug code means ending of the ICD book. You have the list Z code for long term is of drugs. After the tabular list, at ending, you have appendix Z code for long term is of drugs. Ending you can go. Here you will get Z code for long term use of drugs after all the tabular list. So we have the drug name, code, code descriptor. Clear? Here you will get for every drug name, code, and description. Whatever they given, you can go. If suppose you don't know the insulin code, you can check the insulin, you will get the code. Next, in this E series, another concept note down, obesity. Everybody know diabetes complications, right? That's why I'm skipping eyes. So people will go default, no? Next concept, obesity note down. Obesity means how we will code obesity? What is the obesity means? Hmm? Overweight. Then overweight different, obesity different. Check. You will get separate codes, obesity and overweight. We have separate code for overweight and obesity, correct? So what are the things you will code when the patient have obesity? Obesity and BMI. Obesity or morbid obesity when they documented, you will code and BMI, correct? BMI. BMI, how we can code? Based on the BMI value. Suppose if they not mention the BMI value, can you assume the BMI value based on the height and weight? Can you calculate the BMI and can you code? No. If they documented, we can code. Otherwise, leave it. So, whenever they documented BMI value, while we are coding the BMI value, what we need to check? Directly they will give the BMI value, no? Then why we need to check height and weight? So while you are coding the BMI value, what are the things we need to look, guys? Patient age first. We have two types of BMI values, percentile BMI and adult BMI. Percentile BMI 2 to 19 years age. Z68 5 series. Adult BMI based on BMI value or 20 years above. 20 years and above. Okay, well, first you need to check this thing. First, we need to check the patient age. If the patient age was to 19 years but less, we need to go with percentile BMI. If 20 years and above, we need to go with adult BMI codes like Z6, 4, 1, 4, 2, 3, 4, 3, 5, whatever the BMI value, based on the BMI value, it will code. So just to go through the Z68 code in the tabular list. Go to Z68 code in the tabular list. Here they given guideline notes. Look this notes. Of age or older. BMI pediatric codes are used for the person 2 to 19 years of age. These percentiles based on the growth charts published by the Center of Disease Control and Prevention CDC. Okay. So based on the BMI value, we'll get the code. But if the patient was 20 years less, we need to go with percentile BMI. Z68 5 series you will get based on the percentile value. 85th percentile, 95th percentile. What are the percentile we have? Codes you will get. Here Z68 51 52 53 54 56. Clear. Suppose question, patient age was 19 years. Okay. They given the adult BMI code, 41 BMI value they given, and patient is on morbid obesity. How you will code? Patient was morbid obesity. They given the adult BMI 41 BMI value. How you will code?
Morbid obesity and BMI code.
BMI value can we code? No. Okay. We should not code. Suppose coder coded the BMI value without checking the age. The chat went to for the auditor. What is the auditor reaction now? You are the auditor. What is the necessary action you will take? What you will do? Delete the BMI value code. Okay. Delete the BMI value code. In this concept, you will get one question, guys. Patient have 19 years of age. Are they coming with BMI in 41? Coder coded the BMI value. Now the chart went for the auditor. What is the necessary action auditor will take? They will give options: leave it, or correct the code, or do not take any action, or delete the code. Okay. We should not code for the percentile adult BMI. So we need to delete the code. Clear? Next to chapter 5. In the chapter 5, what is the guideline? What is the chapter 5? What is the chapter 5, guys? Mental, behavioral, and neurodevelopmental disorders. Here we have one concept. Any psychoactive substance, the documented use, abuse, dependence, how we need to code. Psychoactive substance, the documented use, abuse, dependence, how we will code. This concept we will get, read this. If the documented psychoactive substance use, abuse, dependence, how we will code, you will get. Read here. These 4 points, if you read, you will get the question. You will get the question like patient coming with alcohol use, abuse, and dependence. How we will code the scenario? Alcohol dependence. Okay, no? If the documented dependence, highest one enough. If the documented use, abuse, we need to code. Clear? One question. Any psychoactive substance, not only alcohol. Suppose they given cannabis, opioid, cocaine, whatever it. Any psychoactive substance, if the documented use, abuse, dependence, go with dependence, either nicotine. Okay, one question you will get in this concept: alcohol use, abuse, dependence. How we will code the scenario? We need to code only alcohol dependence. You will get options like code both, all three, code only dependence, code abuse, code use, like that. We need to code dependence. Next. Chapter has 7. We don't have any guideline. Here we have only glaucoma. Everybody know the glaucoma guidelines. How we need to code the glaucoma? Simple, guys. Which eye they documented the glaucoma? You need to look. Right eye or left eye. Okay, na? ఏ ఐకి గ్లాకోమా ఉందో చెక్ చేసుకోండి. You need to look for the glaucoma type and stage. We have different types of glaucoma: primary angle glaucoma, open angle glaucoma, closer angle glaucoma. Okay, wa? Whenever they documented bilateral glaucoma with the same type, same stage. Stage means mild, moderate, severe. Okay, type means primary angle, open angle, closer angle. So here they given bilateral glaucoma with the same type and stage. We need to go with bilateral code. Okay, what? Bilateral glaucoma code you need to take. For example, they given bilateral mild stage, primary open angle glaucoma. Same type, same stage. We need to go with bilateral. Suppose they given different type or different stage. We need to go with separately. They given same type, but stage different. Separate. Same stage, different type. Separate. Okay, what? Separate. We need to go. Here, see. Bilateral glaucoma, same stage with different type of stages. We need to code separately different stages: mild stage and moderate stage. Chronic angle glaucoma, right eye, moderate stage 1, mild stage 1. Then same type, say different type, same stage, mild stage, but open angle and closer angle. Different type, separate. When the patient have same type, same stage, bilateral. Different type or different stage they documented, go with separate glaucoma codes. Okay, that guideline only we have in the chapter 7. Then hypertension combinations, everybody know, right? Chapter 9. Yes or no, guys? Hypertension, myocardial infarction, CAD, these all the concepts you know or not? Yes, right. Hypertension, CHF, CKD combination, you know, right? So you will get 1 or 2 question: patient coming with hypertension, ESRD, hypertension, chronic systolic heart failure. Okay. So when the patient have CAD and myocardial infarction, what is the sequence first? Myocardial infarction. When we are coding the myocardial infarction, what are the guidelines you need to follow? Initial, subsequent, old MI. Initial means first initial visit. Subsequent, within 4 weeks, if they follow up, are going active treatment. Old means history after 4 weeks or 28 days. Okay, what? So we need to look initial or subsequent or old. Then while you are coding the subsequent MI, we need to look for the subsequent code. While you are coding the initial MI, we need to go with initial myocardial infarction code. When the patient have myocardial infarction and CAD, what is the sequence first? Myocardial infarction. So CAD and angina combinations, you know, right? CAD with angina, CAD CABG, these complications, hypertension, CHF, CKD complications. Okay, well, you will get in the chapter 9. Clear? So tomorrow we can discuss pregnancy, newborn injuries and external causes. Okay. So whatever the doubts you have, you can ask me, I will explain. General doubts also ICD related.